Ladies and gentlemen, it's my great pleasure to share this topic with you, especially with the surgeon. I'm an interventional cardiologist. So my topic is TAVI in low-risk patients, evidence and the consequences. Previously, there are 4 randomized trials compared TAVR with SARA in low-risk AS patients. All those 4 trials mainly include older patients, more than 70 years old, and excluded bicuspid aortic valves. This year, Notion 2 trial results have been reported. For this trial, we all know it included younger patients, less than 75 years old, and also bicuspid aortic stenosis patients were also enrolled in this trial. So later, we will talk about this trial. First, let's look at Notion 1 trial. This trial started at 2009. The objective of this trial is to compare to TAVR with SARA in patients more than 70 years old and eligible for surgery. Primary outcome in this trial is composite endpoints, including any all-cause death, stroke, or myocardial infarction. This is the main inclusion and main exclusion criteria. We look at the patient basic characteristics. Although this trial includes not only low risk but also intermediate risk, actually the more than 80% patients were low risk patients. This is the 2-year results. We can clearly see there were no difference between 2 groups in terms of primary endpoints, all-cause mortality, stroke, or myocardial infarction. If we look at only the low-risk patients, also there was no difference between 2 groups for the primary endpoints. So far, we Notion 2 trial have 10-year follow-up results similar to 2-year results. There were no difference between 2 groups in terms of the all-cause mortality or primary endpoints, the composite endpoints. So Notion 1 trial was first all-comer trial to randomize low-risk patients to TAVR or SAVR. TAVR was safe and effective and comparable to SAVR regarding the composite endpoints after 10 years of the procedure. So next, partner 3 trial, we are all very familiar with this trial. Balloon expandable valve was used in the TAVR group in this trial. And the primary endpoint of this study was composite of endpoints, including all-cause mortality, stroke, and rehospitalization at 1 year. So far, partner trial had reported 10-year follow-up, 5 years follow-up results. There was no difference between 2 groups in terms of the composite endpoints. Death from any cause, stroke, or rehospitalization. Also, the difference between 2 groups for the death from any cause, stroke, or rehospitalization composite endpoints. Still, there is trend that TAVR was better than surgery for these endpoints. We also have some other clinical implications from partner 3 trial. Despite high incidence of halt and reduced lipid motion, lack of an association with serious clinical events does not justify routine use of anticoagulation in all patients. Routine post-CT scan are not indicated based on the result from this trial. Another is Evolute low-risk trial. They also multi-center randomized trial, and the self-expanding valve was used in the TAVR group in this study. The primary endpoint is all-cause mortality, and disabling stroke at 2 years. This is the 1-year result published on 2019. From the primary endpoint, TAVI is non-inferior to SARA. And there were no difference between two groups in terms of all-cause mortality. But we can clearly see the superiority of the TAVI versus SARA in terms of heart failure hospitalization and disabling stroke. Also, for the mean gradients at 12 months, mean EOA at 12 months, and mean KCCQ change, TAVR were superiority to the SAVR for those secondary endpoints. So far, Evolute low-risk trial had reported 4-year results. At 4 year, we can still see the trend that TAVR were better to the SAVR for the all-cause mortality or disabling stroke composite endpoints. So this year, dedicated trial report 1-year result. We all know this is an investigator-initiated multi-center study to compare the TAVR with SAVR in real-world situation. And also, both self-expanding balloon or balloon expanding valve were used in the TAVR group in this study, decided by the physicians themselves. So this is the very significant difference compared with previous trials. We look at the baseline characteristics. Also, the mean STS score was very low. It's 1.8 in TAVR group and 1.9 in the SAVR group. So for the 1 year, we can clearly see the non-inferiority for TAVR compared with SAVR. Actually, there is the two curves separate significantly. We can see the TAVR is performs very good. If I look at the deaths from any cause, TAVR was better to SAVR. Even for the stroke, although there were no significant statistic difference, but still there was a strong trend that TAVR may be better in terms of the stroke events. Also, for other secondary outcomes, for example, disabling stroke was lower in TAVR group, and also new onset atrial fibrillation. TAVR has lower events. TAVR group has more new permanent pacemaker implantation. And for the major life-threatening disabling bleeding, TAVI is better than SAVR. So for the decade study, among patients with severe aortic stenosis at low or intermediate surgery risk, TAVI was non-inferior to SAVR with respect to death from any cause or stroke at 1 year. Notion 2 trial is a very good trial for today's topic because it enrolled younger patients, less than 75 years, also enrolled bicuspid patients compared with previous trial. The primary endpoint of this study is a composite of death, stroke, or rehospitalization. From the baseline STS score, we can clearly see it's very low, 1.0 in both groups, definitely low-risk patients. And for the bicuspid aortic valve patients, it's 36% in TAVR group and 34% in surgery. We look at the primary outcome. There were no difference between the group for the death, stroke, or rehospitalization, or for the death or disabling stroke. This is the individual components of the primary endpoints. Also, there were no difference between the TAVI and the SAVI. Similar to previous trial, there were less new onset atrial fibrillation in TAVI group and shorter length of index hospitalization. But the TAVI group has more new permanent pacemaker implantation and moderate or greater parallel regurgitation. We look at the different cohort, tricuspid or bicuspid cohort. For the tricuspid cohort, the results similar to the whole cohort, but we look at the bicuspid cohort, there was clear change, and the TAVR were worse than surgery for the primary endpoints. Also, for the death or disabling stroke, TAVR was worse, maybe worse. If there were significant trends, TAVR was worse. Previous is the study from Western world, and we have two domestic study for the TAVR in China, especially for the bicuspid patients. First, the CARRY study is led by Mo Chen from Huaxi Hospital, and also my center attend this study. It's multi-center registry study. This is the baseline. We can collect totally more than 1,000 patients. The mean age is 73 years old. And we look at the valve classification. Nearly half of the patients were bicuspid valve. In some area, like northwestern area of China, it's even higher. So this is the real world situation even now. Maybe in many centers in China, half of the patients is with bicuspid aortic valve. This is the hospital clinical outcomes. The all-cause mortality is 2.2%, and the pacemaker implantation is 11%. Also, the major bleeding is 0.5%. We look at the comparison between the bicuspid aortic valve and tricuspid valve. This is a 1 year follow-up. There were no difference between the two kinds of the valve patients, but clearly see the change between the two groups. From our study, bicuspid valve results even better than the tricuspid aortic valve. But I think we need more randomized trial and need more longer follow-up for those patients. So the CARRY study shows, compared to tricuspid aortic valve, those with bicuspid valve has higher rate of general anesthesia and bronchodilation, hemodynamic significantly improved after TAVR in both valve type. The in-hospital complication rates were not significantly different between the two groups. Our center also lead a multi-center registry in northeast of China. Totally 9 centers attended this study. Finally, we enrolled 316 patients. Mean age is 73 years old. And for the SCI score, we can clearly see nearly 70% of patients were low-risk patients. And about more than half patients were bicuspid aortic valve. This is the 1 year results for the clinical events. we can see there was not a significant difference between the two groups for those endpoints. For example, the all-cause death is 6% versus 10%, and disabled stroke were relatively low in this study. Also, pacemaker rate, bicuspid aortic valve has lower pacemaker implantation, maybe because of downsizing in most bicuspid aortic valve patients. So take-home message across major outcomes, including all-cause mortality, cardiovascular mortality, disabling stroke, myocardial infarction, aortic reintervention, TAVI and SAVI perform similarly. TAVI patients more likely to need a pacemaker, but less likely to develop atrial fibrillation. Notion 2 trial suggested that TAVI outcomes in young bicuspid aortic stenosis patients were less favorable. However, primary data from China showed promising results in low-risk bicuspid aortic valve patients, but larger scale randomized trials are needed to further evaluate those results. Thank you so much.